Yeah.
Good morning, good afternoon, good evening, ladies and gentlemen, depending upon which part of the world you are joining us from. And I am Dr. Vijay Agarwal. I'm the president of CAHO. It's my proud privilege to welcome you all to this yet another session of ISQua CAHO webinar, which has really become like a landmark, and people forward to the first Tuesday of every month to listen to this exciting event. It is again another privilege of mine to introduce you my dear friend and friend of CAHO, Dr. Naveen Thomas, who is the head of the Baptist Children's Hospital. He's one of our very eminent senior surgeons with vast experience of more than 26 years of general surgery and even 20 years in pediatric surgery. And he has been an examiner of the for DNB for surgery. He's also a principal assessor for NABH, which is the National Accreditation Board for Hospitals and Healthcare Providers, and has a passion to be involved in the quality processes of healthcare quality. His past experience includes working as a senior tutor in surgery at CMC Vellore, which was way back in 1998-99. And as a fellow in pediatric transplantation at Children's Hospital at Sydney from 2009 to 11, and as a clinical associate lecturer in the Sydney Medical School at the same time. So I am going to leave it now to Dr. Naveen Thomas to introduce the very, very eminent speakers to talk about measuring culture of safety and just culture. I think a fantastic topic. Over to you, Dr. Naveen Thomas.
Yeah, thank you so much, Dr. Agarwal. After an introduction like that, I can't wait to hear myself. So this evening, or whatever time it is in different parts, it's my privilege to anchor this on behalf of CAHO. It's it's a recognition of CAHO's stellar work that so many have appreciated the webinars that are being conducted and the many programs. So we are thankful for the legacy that CAHO continues and the leadership. So thank you very much. Let me first of all introduce the speakers for today. Dr. Ross Baker is professor in the Institute of Health Policy, Management and Evaluation in University of Toronto, and the program lead in quality improvement and patient safety. So the current research topics include patient safety, patient engagement, integrated care systems. So he's had a major focus and impact on patient safety research for over 20 years. Co-principal investigator of the Canadian Adverse Event Study, published in 2004. So the Canadian Medical Association Journal identified that, that publication identified that 7.5% of Canadian hospital patients suffered unintentional harm resulting from patient care or intended patient care. So I'm sure it's, it was an honest study. It's relevant to all the countries. So many countries he's been involved in this aspect of patient safety culture. So from 2005 to 2010, Dr. Baker chaired the Research and Evaluation Advisory Committee of the Canadian Patient Safety Institute, and 2006 to 10, he served as co-chair of the World Health Organization Review of Patient Safety Methods and Measures. So Dr. Baker is a fellow of the Canadian Academy of Health Sciences. In October 2017, he received the Bearer Flood Prize from the Institute of Health Services and Policy Research of the Canadian Institute of Health Services Research in recognition of the outstanding contribution to health services and policy research and care delivery in Canada. It's our privilege and to welcome you and Dr. Jennifer Gutberg, yes, PhD candidate at the University of Toronto, Institute of Health Policy, Management and Evaluation. Her research examines health system transformation across acute and primary care sectors. Particular passion for studying leadership, organizational culture, and patient safety. Her research has been supported by fellowships from the Fonds de Recherche du Quebec, you will have to pronounce it for us, as well, and the Health System Performance Network. So it's a, she's in the thick of things. So patient safety workshop series with McGill University's continuing professional development department, and you've been associated with all that. In addition to her research, Jenny has also been engaged in applied patient safety efforts to work in the acute and long-term care sectors with the Canadian Patient Safety Institute, as well as the Institute for Safe Medication Practices Canada. So we can't have better people than these to address the topic for today, which is patient safety culture and just culture in healthcare. So very relevant as we are all ears. So over to Dr. Rob Baker.
Thank you very much, Dr. Thomas, and thanks to CAHO and ISQua for organizing these seminars. It's very impressive to see so many people from across the globe who are participating in your seminar. So many congratulations to the organizers for arranging these events. You obviously have worked very hard to create something which many people want to see. So my colleague Jennifer and I are focusing on what we think is a critical issue for all of us who are interested in improving the performance on patient safety, and that is understanding, measuring, and then improving patient safety culture as a critical element to improving the care that we're providing to patients around the world. And as Dr. Thomas said, I've been involved in this patient safety work for more than 20 years right now. And when we first came into it, we thought now that we know what the problem is, that we'll be able to really focus on it and make a big difference in a short period of time. And here we are 20 years later, we're still working hard to understand the nature of the issues and the interventions that are necessary to move forward. So we're going to do this in 4 parts. The first part is around this issue about what is patient safety culture and why is it important? What do we gain from measuring and working on culture, which seems like a very ephemeral, and soft subject for people who are engaged in the very important technical work of healthcare and medicine. Then the second section is going to be around the role of leaders across the organization, frontline leaders, middle level leaders, and senior leaders in measuring and improving patient safety culture. We'll talk a little about the nature of the surveys that people are using and what the elements that are included in those surveys. And then we'll end by talking about how to integrate this work around patient safety culture measurement into a safety program. So really trying to provide an overview of some of these issues, really to point you towards some resources that may be helpful as you're working on these issues. So let me start with why we're doing this. And it has to do with this problem that I mentioned right from the start. It's more than 30 years since the Harvard Medical Practice Study in 1991, which was the first major research study that showed the quite astonishing number of patients who are harmed, unintentionally harmed, as a result of their care. And as everybody on this call likely knows, it was a little less than a decade later that the Institute of Medicine in the US released their report To Err is Human, which was a landmark event. It really changed the way we thought about patient safety. And everywhere around the globe now, those reports and other reports in different countries have really focused on the issue of patient safety. Yet we still see enormous numbers of events around the world in high-income countries, in middle-income countries, and low-income countries. The nature of those events varies somewhat, but it's still a consistent problem moving forward. And I have on the slide here just one graphic from a recent study in Canada of events in intensive care units. And 1 out of 4 patients in ICUs in the western province of Alberta experienced a patient safety event, an adverse event, unintended harm as a result of their care. Now, the issue about how many of those might be preventable is not being directly addressed here, but it just raises our attention to the fact that now, even 20 years after we all recognize this problem of patient safety, it continues to be an issue, not just in Canada, but around the globe. And so therefore we have to think about what we need to do. And as many of you know, we've spent a lot of time in the last 20 years asking the question, what are the interventions? What can we do differently to help our patients and to help our doctors and nurses and pharmacists to ensure that they're unlikely to do the things that can lead to this unintended harm? And many interventions have been designed, tested, and implemented. But as the slide says, the results have often been very disappointing. Small-scale studies that seem to work in local units don't scale and spread very effectively. And this table on the right comes from an article by Paul Shakel and colleagues who a few years ago went back to the literature and asked the question, so what are the evidence-based patient safety strategies that we can use to reduce the amount of harm that patients are going to experience? And you see this list of those that are strongly encouraged and those that are just encouraged. And the challenge is, even with that knowledge, even with those interventions, we still struggle to make a difference for patients in many different settings. And so we have to ask the question, why is that? Why is it so hard to improve patient safety culture or patient safety? And the answer is, on this slide, it's around the need to not only focus on interventions, the technical issues that we want our teams to be aware of, the information and approaches, the bundles of interventions, medication reconciliation, checklists, and all these other things that we've heard about and used for decades now. They only work in environments where the culture supports these kinds of efforts moving forward. So I put on this slide a definition that comes from an article written by Sally Weaver, who was actually prompted by Paul Shakel, the guy who organized this review about top strategies to improve patient safety. And she focused on patient safety culture because she said this enables clinicians and staff to really understand that what they see in their daily work, what they're doing, is the key to success moving forward. So having those interventions on their own is not effective unless they're put in environments where staff are encouraged to report things that aren't going well, the errors that are inadvertently made in the busy, pressed work of frontline staff. We need to see the things that go wrong, report them, learn from them, and try to build an environment that's more supportive of creating safe care. So patient safety culture shapes the perceptions of frontline staff and staff throughout the organization about ways in which we can work differently and how to use those different ways to promote, support, and really move forward in our effort to create safer care. This slide really goes back to that issue about moving from a blame culture to a learning culture. And so patient safety culture is really important because it really focuses our attention on this issue of helping people to understand that most of the time, not all the time, but most of the time, when things go wrong, it's not the fault of an individual or an individual alone. It's the fault of these busy, complex systems we all work in that don't always offer reliable ways to provide care. So the biggest challenge to creating safety is the barriers to learning from the things that go wrong right now. And the biggest barrier to learning is this fear that if individuals report problems in their daily work, that they will be blamed for them. And that the result of this will be individual discipline rather than system learning. So we need to now focus, we need to move away. Still, 20 years later, after recognizing this is a critical issue, we still see situations where when things go wrong, people are blamed unnecessarily for the events that occur. Rather than seeing these as errors alone, we need to see them as opportunities, because these things repeat themselves. There are constant themes moving forward in healthcare about things that go wrong, and we need to now take the advantage of that learning to build more robust, safer systems. So patient safety interventions are very important. I'm not saying they're not important. They're critical moving forward, but they only flourish in an environment that is rich and supportive. They don't flourish in an environment where people are discouraged from reporting adverse events. So the items that are on this slide are really giving us a sense of the kinds of issues that happen in environments that really support patient safety and patient safety culture. We have effective teamwork and communication. We have strong clinical leadership. We have local data and accountability for performance. We have the understanding of the methods and approaches to improve the way in which we deliver care, the quality improvement efforts, which are closely tied to patient safety. We have ongoing learning and reflection, which is a hard thing to do in the busy clinical environments we're in, but it's really important moving forward. And it's all enabled by support, particularly from senior leaders who support others in this learning journey moving forward. So I want to pause for a second here, because we wanted to get your view about whether or not you're measuring patient safety culture in your organization. And if so, are you using one of the tools? We've only listed 3 of the common tools here. We recognize there are many others. And Jennifer will talk about that in more detail a little while along. But we're going to pause for a minute and see if you can answer this poll. Do you currently measure patient safety culture in your organization? And if so, do you use one of these tools to do so? If you use another tool, you can just put the name of that tool in the chat. So let me pause there and let everybody answer that question. Okay, so that's a little background here. And we were asked to talk a little bit about just culture. So let me just focus on that. And many of you will know the name James Reason. James Reason was a professor of psychology at Manchester University in the UK, and the person most associated with this idea about just culture, because we have a problem in patient safety culture when we say we need to focus on systems. Because in many events, it's not just the systems, it's a combination of individual behavior and the larger system context in which those behaviors occur. And so blaming individuals for errors that result from system deficiency is wrong. And as I've already said, it prevents us from learning what's actually happened. It creates this toxic culture that disables that kind of learning. But at the same time, we do know that there are individuals who don't have the knowledge, the skills, or other attributes that are necessary to offer safe, reliable, high quality care. So we need a way to distinguish between the situations in which the issues are largely system-based and the situations in which they're largely individual-based. And often we have a bit of both moving forward. So Reason gave us this tool that I'm going to show you in a minute that allows us to identify individual culpability, individual responsibility, and system issues moving forward, so that we can differentiate what we need to do in each system as we move forward. Here's the tool here. So I won't spend a lot of time on this, but it's a series of questions that really allow us to distinguish, first of all, whether or not the actions that led to the event were intended. Were the actions intended, and did they have the consequences that were intended? Was the individual provider taking an unauthorized substance, medication, or alcohol, or other things? And if so, did they have a medical condition that justified taking that or not? Did they knowingly violate safe operating procedures? In other words, did they not follow protocol Were they experimenting with new procedures that didn't have any evidence to support them? And the most interesting one of this is the substitution test. So it's very easy in hindsight to come back and judge somebody for an event that goes wrong when we know what the situation was that prompted that event, but we don't fully experience the mindset and the challenge for the individual provider or team at the moment that they're trying to make up their mind. And in order to test whether or not that there's an individual culpability here, reason suggests that we do the substitution test, which is to say, would a qualified person, a different person who was in this situation, who knew what the individual in this situation knew, be likely to make the same decision? Was this a reasonable conclusion based on the situation that that physician or nurse or pharmacist was facing? And if it wasn't, then we have this question about deficiencies in training and selection or inexperience, which could require different kinds of corrective behaviors. So the decision tree allows us to separate out situations where individuals are at fault from situations where it's really a poorly designed system that's letting individuals down. It's not really giving them the tools, the knowledge, and support in order to make their decisions moving forward. So just culture and patient safety culture in general are really critical issues. And I feel that although many people talk about this, there's still a lack of attention to these issues and to the use of the measurement of patient safety cultures. So in the last 20 years, there's been a lot of work by very experienced researchers developing a variety of different tools moving forward here. And this is just the three prominent ones that we've listed here. And I'm not sure how well they've been adopted in other parts of the globe. But these are ones that have been very useful and very faithful and valid to the underlying concepts of patient safety culture that have been developed by Reason and other scholars in this area. So we have the survey tools. We have the ability to go out and measure patient safety culture. But the problem is, in most settings, measurement by itself doesn't lead to improvement. We have to figure out how to translate the results of those surveys into action at the front line and throughout the organization. And a friend and colleague of mine, Mark Fleming, who works in the province of Nova Scotia, he's a professor in the province of Nova Scotia, and he's an organizational psychologist, has this nice little summary where he says, without guidance, without some tools and a way to actually use the results from patient safety cultures, the surveys themselves are like describing the water to a drowning man. They tell you how bad things are, but they do little to help in solving the problem. So we want to help, not that you're drowning, but we want to help everybody to understand how to use patient safety culture tools more effectively moving forward. And there's a variety of articles. This is one from the BMA Journal of Quality and Safety by Morella and colleagues, reviewing the evidence for strategies to improve patient safety culture in hospitals. A very nice review of this moving forward. And the other article that I would mention is the one that I talked about from Sally Weaver, which is also a review of strategies for improving patient safety culture. And there's a strong similarity in the results of this, so I'm only showing one. But it's around doing things that show the support of leaders for teams, leadership walkarounds, that builds team communication, a team interaction, that overcome the sort of often common hierarchies that we see in frontline care, that limit the ability of staff to actually express their fears, concerns, and issues that they see. It's around using simulation effectively to test out the responsiveness of teams, their ability to work effectively in high pressure clinical situations. And that's an important tool that's developed considerably in the last 20 years. And it's around developing a variety of different strategies to build unit capability and unit interest in reporting and learning from the events that occur in your situations. I'll also point to this article from Mark Fleming, who I mentioned just a minute or two ago, on and he talked about the Patient Safety Culture Improvement Tool. And it's a short tool that really asks the question for various elements, quickly, highly related to patient safety culture. What's the level of maturity of our leaders, of our staff, of our reporting systems that will enable us not only to understand the number of events, but to understand the context in which those events are occurring, so that we can ask the question, are our leaders prepared? Are our frontline staff prepared? Do they get the right support from their quality and safety staff in order to actually work on the problems that they see in front of them? So that's the first section, and I'm going to turn it over to Jennifer, who's going to talk about the next issue around how do we integrate this knowledge across the organization. Jennifer?
Thank you so much, Ross. And hello, everyone. It's, as Ross said, so wonderful to see so many people from across the globe here. Truly privileged to be speaking with you all. And Ross has really segued perfectly into what I want to talk about, because he's clearly highlighted that measurement of safety culture is indeed a necessary component, but in and of itself, it's insufficient to really bring about change. And this is because culture change is complex, and I've represented this through this tangled web of yarn. And the complexity comes from there being so many professions, so many challenges, so many issues of hierarchy that go on within healthcare organizations, where your planned input of your safety strategy doesn't always lead to the expected output of the change in safety culture the way you expect. And so when you take this image of the tangled web of yarn, you put a piece in, and sometimes you can't find it in the other end, or it comes out looking completely frayed. And you're often asking, why? What happened? And so what I'm going to talk about is how to address a little bit of the catch-22 around measuring safety culture, which is that you need to measure it, but you can't measure it without having a culture and an environment and a context that enables that measurement to happen in a meaningful and effective way. So the way that we propose that this is important to start looking at is to get a line of sight into what's happening in that tangled web of yarn. And you do that by looking at really all levels of the organization and all the key players that are involved in this. So I'll circle back to this a little bit later, but what I'm really highlighting here is the cyclical relationship and the importance of senior leaders, middle managers, and clinicians and staff, who each play a different role in enabling an environment for measuring safety culture, but often are not seen jointly. It's either seen as a top-down initiative from senior leadership or as a solely bottom-up effort that happens at one unit at a time, one department at a time. And so senior leaders enable safety, climate, and culture. They build capacity for change, and they create a platform for measurement. And so there's a wonderful tool that comes out of Canada, which is the Patient Safety Culture Bundle for CEOs and senior leaders. And so this bundle is built off of a theoretical framework developed by Sarah Singer and Tim Voges. And their work was based on an extensive systematic review of patient safety and safety culture interventions. Now, the key here is that there are three categories: enabling, where the organizational priority setting, leadership practices that motivate the pursuit of safety. So these are things around, for instance, is there a quality and safety vision in the organization? Is there a strategic plan? Are there goals with input from all levels of the organization and outside from patients? Is there resources and infrastructure to prioritize safety? The next piece is the enacting. And this is where we start to see the middle managers and the frontline clinicians come into play, because these are the actions that improve patient safety and that allow that enabled environment to come into play in real time. And so these are things around care processes, whether they're standardized, whether communication has protocols, whether patient and family engagement is involved in safety issues. And then the last piece is learning. And this is the piece that allows for the reinforcement and the continuing quality improvement that assures that lessons are not lost from incidents and from errors. And so even from this senior leadership bundle, we can already see how there's a clear role for others in the organization, which brings me to the next group, which is middle managers. Middle managers are uniquely positioned to implement measurement tools and strategies which allow them to guide, adapt, and communicate safety issues to their frontline staff. Now, middle managers have a pretty unique situation in their organizations, and particularly in hospitals. At their best, in an environment where they are given the access and the resources, they have the opportunity to really act as conduits for safety strategies. They can be champions for measurement efforts and for culture change efforts. Unfortunately, on the flip side, when the environment is not supportive, when senior leaders have not enabled a climate of change, of support, of innovation, they can often be barriers to change because they do not see the support and they do not feel supported in their organizations. So really making sure not to lose sight of this pretty large and substantive group of key players is really important, because oftentimes we see safety and safety culture efforts as either a top-down or a bottom-up initiative. So the focus might be on senior leaders, or it might be on frontline clinicians, and then all the key individuals that implement these efforts really get lost in the middle. And this brings me to the last group that I mentioned, which is physicians, nurses, and other clinicians and care providers who action the results from the measurements and tailor them to their existing environments. And again, I'll circle back to this a little later, but the key point here is that it's the people on the front lines who will be filling out these tools, who will be pointing to the errors and the challenges and the barriers to truly changing and addressing safety culture in their organization. And if it's not done in a manner that is supportive of their efforts, of the realities of their challenges, and allows them to make their own recommendations and perhaps build in their own strategies for measuring or for implementing these interventions that Ross mentioned earlier, then they will also lose their motivation. They will see measurement as a regulatory requirement and not something that they are going to value and take forward in what they do next. So we've talked a little bit about safety, we've talked a bit about culture, we've talked about creating that environment that allows measurement to happen, but now I want to spend a little bit of time on talking about the actual tools and surveys. So as Ross mentioned, there are a myriad of tools, as you can see from this table here, and there's no need to read through all of them unless there are some that you actually use in your organization. And I haven't seen the chat yet, but I hope that those of you who responded outside of the 3 options that we listed did share the tools that you use, because this is sourced from a report from the Health Foundation in 2011. And really, it's only grown exponentially since then, the available suite of measurement tools that are available. The key for today is not so much which tool should you use or going over each tool and the differences between, but understanding why you might consider one versus the other and what the underlying rationale might be and what factors you need to keep in mind as you not only think about implementing a measurement tool, but taking it further to actioning change. And so there are a couple of key factors that you might want to keep in mind here. The first, which is pretty universal and a baseline for anyone looking at this, is the psychometric properties of the survey. And this isn't only for research purposes, it's really practically fundamentally important, because you want to make sure that the tool that you're using has been tested in the clinical environment that you're exploring, has been tested with the populations that you're looking at, has been tested in the country, it has been translated into languages that you might be using. And above all, you want to make sure that the tool that you're using, because it is quite resource intensive to share these tools and to launch and disseminate a survey into your organization, that they measure what you want to measure, and that you can look over time and see trends and changes across your organization. Otherwise, all of this wonderful data that you're collecting is not going to be valuable. The other thing to consider is the context. And this, again, goes back to what I said around your clinical setting. Are you in an ICU? Are you in a hospital? Are you outside of the hospital setting entirely and looking in primary care, in mental health care? Because a lot of these tools have been developed within the hospital context, but many have been adapted to other environments. And so you want to assure that, again, the right questions are being asked for your environment. Now, the third piece, and what I would argue is probably the most important factor to consider when thinking about which tool to use, is what are your goals for measurement? Yes, ultimately everyone's goal is to change their culture, but there's a lot of other valid and important reasons to measure patient safety culture. It could be for benchmarking purposes. It could be to set the foundation for safety. Perhaps you're an organization that is not yet measuring safety culture and you just want to get a baseline. You want to give people a shared language to understand. And if everyone has seen the same tool, this starts to give them a shared framework and a mental model for how to understand safety culture. Perhaps it's for regulatory purposes. Perhaps it's for auditing, whether internal or external. And then the other question you might want to ask yourself is, how deeply do you plan to engage in these results with your organization? Is this something that you really just want to capture trends over time for quality assurance purposes? Or is this something that you want to spend a lot of deep time exploring because some tools are better equipped to do that? So the 3 tools that I've highlighted here and the ones that we included in the poll just earlier are chosen because they are well validated and because they approach the safety culture measurement from a little bit of a different perspective. So first, we have the hospital survey on patient safety culture, and I'll be talking about the most recent version. And it's great to see that I think nearly 50% of the audience had selected that they use this tool in their organization. So glad to see that it's applicable. So many of you will probably already know the dimensions that are explored in this, and so I'm not going to go over each of them. But what's great about this tool is that while it was developed in the United States from the Agency for Healthcare Research and Quality, it's been tested in a myriad of other contexts. It's been tested in Canada, in the Netherlands, in Saudi Arabia, in Taiwan, in Lebanon, and these are just a number of countries off the top of my head. There are many others. So it has strong psychometric properties. It's been well validated. And what's really key is that the dimensions that it captures are they make sense. They're very organic. It highlights, for instance, the difference between supervisor or clinical leader support for patient safety versus hospital management support for patient safety. Because as I just finished saying, there's a big difference between having the support from the senior leadership who enable the environment versus your middle manager or your direct supervisor who's actually responsible for implementing these strategies. There's also responses to error, teamwork, communication, and a whole myriad of other ones. Now, the only challenge to this tool is that while it's been validated in many countries, it still has a little ways to go. There are some environments where it hasn't yet been tested. And some of these dimensions are a little bit less well validated than others. But at the end of the day, what's really important here is just how your organization takes up the results of this survey. So now on to the next one, the Safety Attitudes Questionnaire. This one is interesting because it was developed based on the safety work in the aviation industry, and it has several decades worth of evidence to back it up before it was adapted into the healthcare context. And what's a little different about the Safety Attitudes Questionnaire is that it's measuring individual perceptions or attitudes about safety culture. So there's a slight difference between trying to measure the culture itself versus trying to measure individuals' perceptions. And a great way to demonstrate this difference and what they refer to as safety climate versus safety culture, one item in the safety climate dimension is, I would feel safe receiving care in this organization. This doesn't speak to why someone would feel safe or what underlying processes might explain that feeling, but it does give a snapshot that indicates either, yes, okay, we're doing something right, people feel safe, let's explore this a little further, versus, okay, here's a big red flag. If our own staff don't feel safe being treated in this organization, we need to probe deeper and figure out what's going on. And so this tool you might want to consider, and I saw that quite a lot of people used it also, I think about 23%, which is fantastic. This might be great for organizations that are either early on in their trajectory for measurement or maybe haven't even yet started implementing measurement, because as I was alluding to earlier, it gives a common language for safety issues, and it also gives that early snapshot of what's going on in your organization. And the third one that I'm going to highlight is the Manchester Patient Safety Framework. Now, this one is particularly interesting because it's a little bit newer and the evidence is a little bit less robust, but it's still growing. And what's really neat about this tool is that it's not just about the dimensions that are being measured around safety culture. It really takes a holistic view of safety culture that looks at the entire organization. And this is based off of Westrom's theory of organizational safety. There are 3, which have since been expanded to 5 typologies of safety and in the organization. And these are pathological, where safety incidents are swept under the rug and simply not talked about, where a scapegoat is used to blame for issues and then move on with the status quo. There's the reactive typology, where safety is discussed and addressed, but only in direct response to an incident or an error. There's the bureaucratic approach where safety, there are procedures and policies for safety, but they're very rigid, and there's very little space for flexibility and reflexivity around opportunities for how could we improve what we're doing here. Next, there's the proactive, where safety is a priority in the organization. It is discussed at all levels. It is considered. There are root cause analyses. There is a system lens that balances that view from the individual to system factors and following reasons decision tree. And then lastly, there's the generative. And the biggest difference between the proactive and the generative is whereas proactive, safety is a priority in the organization, in a generative typology, safety is the top priority of the organization. It's embedded into hiring practices, into training practices, into the foundation of what the organization is doing. And the key thing that's really interesting about this framework is its emphasis on maturity and growth. So you can see each of those typologies mapped out. And so each of the 10 dimensions of this particular tool have their own category of, is it pathological? Is it reactive? Is it generative? And not only does it give a model of growth, but it shows a path forward. It gives examples of what a generative continuous quality improvement culture might look like. It gives an idea of what a pathological one might look like. It also recognizes that organizations ebb and flow, and at some points in time, there may be growth, and at some point you may be receding. And when you look at the 10 dimensions, they're not drastically different from what was covered in the other 2 tools that I highlighted. The difference here is in how it's being explored and how it's being leveraged. So this would be a wonderful tool to use if your organization is really deep in its trajectory on safety culture, saying this is going to be a major strategic priority for us for the next few years, and we want to give the time to explore how to address each of these issues, understand where we're at, and envision what our future path might be towards that end. So now we're going to take a little poll break again. So since we have talked about which tools you use, and it's wonderful to see that so many of you have in fact already implemented measurement in your organization, what I want to know is what trends have you seen in your organizations based on the results of your patient safety culture surveys? So have you seen visible improvements in scores over time? Has there been no change or little improvement? Or have you actually seen a visible reduction in safety scores over time? And of course, this would be a point to just comment that while you're filling out this poll, obviously in the COVID environment, what's happened over the past year, I'm sure the situations are drastically different than what they might normally be in your organizations, and recognizing that everyone has quite literally been in survival mode for the past 18 months. But even with that in mind, that gives an opportunity for the organization to really do some introspective work and say, this is what we had to face. We've all seen the worst of it. Now, how can we come out the other side and really just be open and transparent and make the most of this? Fantastic. Okay, so great to see that the majority have seen visible improvements in scores over time. And generally speaking, that would be to be expected. Again, the measurement in and of itself is a starting point, and seeing the measurement continue over time opens that conversation. And also not surprising that there's a little bit of diversity in these results. So very interesting. And if anyone wants to share in the chat why these trends have happened in their organization, what may have contributed to it, how they're planning on addressing it, would love to hear. So we've talked about all of these factors. Now, how do we bring it all together? And this goes back to what I was saying earlier about setting the context. So you need all leaders in the organization to create the environment that allows for measurement, but you also need all those individuals in the organization to be involved in how that measurement gets actioned into concrete change. And this is through reinforcing the cycle of safety culture. So when leaders effectively measure and use patient safety culture, they should adopt the principles of mindfulness and high reliability organizing. And I will talk about high reliability organizations in just one quick second, but it's probably a concept that at least some of you, if not many of you, are already familiar with. And the key to high reliability organizing is all about creating presence. So being present allows a constant focus on safety in the organization. This in turn creates meaning and psychological ownership for frontline workers, which then allows them to initiate their own safety improvements. Through this, patient safety culture measurement and change becomes both a top-down and bottom-up endeavor, which reinforces that culture of safety. And so really, this is another way that you can use measurement as an intervention in and of itself to continue to build up that safety culture. And so I will just very quickly go over these principles of mindfulness and high reliability for those who aren't familiar, because it goes to so much of what we've spoken about today. It goes, especially you can see it in the Manchester Patient Safety Framework. That's really the foundation for how that tool was developed. So the 5 principles are: first, preoccupation with failure, which is about asking the question, what could we be missing? Then there's reluctance to simplify, which is about asking, what assumptions are we making? And if we are focusing on failure, are we looking at the lowest common denominator? Are we looking at the easiest solution to understand the issue instead of going deeper? Next, you have sensitivity to operations, which is basically asking the question, what is going on around me? And this might look different depending on where you're at. If you're a frontline provider, that might look at what's going on around me in this clinical interaction, as opposed to a manager who might be saying, what's going on in other parts of the organization that might affect me? Then you have deference to expertise, which is about asking who is the expert and are they able to share their expertise openly? And this is one of the biggest challenges in healthcare. And last but not least, commitment to resilience. The previous 4 dimensions are all about avoiding events, adverse events. Commitment to resilience is about how does the organization respond when an adverse event or an incident has occurred. It's about discussing what went well, what went wrong, and how can we avoid making the same mistakes. So the key takeaways from all of this: the aim of measurement should be that making sure that patient safety culture measurement and survey tool use is a core activity in improving care, not simply a checkbox to mark off. The challenge, as we've been discussing, is that safety practices are at risk of being parked to the side and seen as an administrative burden. Often we have departments and units and areas of patient safety that develop these wonderful initiatives, but then unfortunately, by the time they've received support from senior leadership and have been disseminated across the organization, have lost steam, have lost momentum, and don't have the meaning and the buy-in of those who have been affected by it and are just seen as yet another bureaucratic step. So how do you achieve success and overcome this? Extending our view of safety and embedding safety enhancing activities into the organizational, the clinical, and the managerial practices continuously. So now I will just go into a closing poll. So what I wanted to ask is, going forward, what are your key needs or remaining challenges around patient safety culture? So the options are translating survey results into action, identifying the strategies to build stronger teams or supportive cultures, linking safety culture measurement to concrete safety challenges in your organization, or others. And again, I would encourage you to please share and chat. And I see there's been quite a lot of activity, so I'm really looking forward to hearing what everyone has had to say. So we'll just give that a quick moment for people to have some time to share. And in the meantime, I will pass it off to Ross to say any final concluding words before we go to the Q&A.
Thanks, Jennifer, and thanks to everybody for the great comments in chat. But I think we should move on to the question and answers after we see the poll results.
So that's great. There's quite a lot of different perspectives. Identifying strategies to build stronger teams and supportive cultures has come out, but it's followed slowly behind by translating survey results into action. So hopefully we'll have an opportunity to address this in the Q&A portion.
There's a number of questions already in chat, so maybe we could just pick up some of those. Renu Chaudhary asks how to interpret the survey results if staff do not respond to the survey. So this is the critical issue, right? So if people see a survey as not a valued activity, they don't see management and their clinical leaders paying any attention to it, then they ask the question, and it's a reasonable question, why should I fill out this survey if it's only going to be put on a shelf somewhere? So it's really a leadership responsibility to let people know why it's important to do this and to visibly show how those survey results are influencing decisions made within the organization. And I could say this is a problem everywhere. It's a problem in Canada. And I'm on a board of a hospital that has this problem. And it's, it's partly the nature of the work that we're in. Everybody is very busy, particularly in the COVID period right now. So we have to make sure that people understand that this has a translation into efforts to support frontline staff. And if staff don't see that, if they think that's just a marketing strategy, then they're gonna quickly realize that this is not something that is going to be a central and visible activity for the organization.
And I'll just add to that in and of itself, sometimes the lack of response might also reflect the culture of the organization. That people don't feel safe responding honestly, the easiest solution might be for them simply not respond at all. So again, as Ross said, it falls back to a leadership responsibility and a leadership issue to address.
Yeah, thank you very much. I think the importance of building a culture, from the baseline, from bottoms up approach, so important. Professor Baker has already mentioned 25% admissions having at least one event or more of, the adverse events. Just moving on from blame culture to learning culture, becoming a just culture, and then going on to measuring that, and the safety attitudes questionnaires, reinforcing the cycle of safety culture. I think very important things handled there. Thank you so much. I think there are more questions which are coming up.
Another one here that Jennifer and I can respond to. How can leadership involve patients and relatives on safety culture? So I would just start on this. I mean, I think that's a really interesting and important question, because in many places now around the world, people are involving patients in many hospital committees, many different hospital activities, because they know the patient's perspective is very unique. In fact, in many places, the patient is the only one who experiences the full experience of healthcare, right? Each individual provider sees what she or he does for the patient, but the patient sees the whole story. This is an area where leaders need to role model. They need to show that this is important. They need to show that patients have important views going forward, and they need to support patients in expressing those views. So I sit on a board of a large hospital in Toronto, and we put patients on all our committees, including the board committees, so that the patients can talk about, in the quality committee, talk about their experience of care. And sometimes it slows down the conversation a little bit, but many times it's a unique experience to hear the patient talk about their issues moving forward. So I really encourage you to do this in a way that recruits, supports, and integrates the patients into this discussion moving forward, because they can tell you a lot about the safety culture from the experiences that they've had in hospitals and other settings.
A very interesting question which has come up. How do you motivate the leadership to engage in safety culture and making it? I think that's a very different perspective of the whole thing. I think over to you to answer this.
So that is a great question, Dr. Thomas, because, as you know from your own experience, and other people on this webinar have also seen, it's a very challenging time. There's many things to do, and many leaders might say, I don't have time for this. I have so many other things. The government wants me to write reports. The staff want me to spend more time on activities with them, et cetera, et cetera. But I would say the most important thing to do is to go to a place that has a strong patient safety culture and experience it firsthand. Talk to the leaders, but more important than talking to the leaders is to go on the units in the hospital that have strong safety cultures and see what it feels like. It can be very different, very controlled, very, very calm, because people can rely on each other. They know that they can raise uncomfortable issues. Doctor, did you look at this patient? Because I think this patient has something that you need to be attending to, right? You can't say that in many places around the globe without being criticized. So a patient safety culture has to be experienced to understand it. And once you see it, it becomes a very attractive goal for an organization. So I really encourage people not just to look at this as an academic exercise. Yes, it is an academic exercise, but it's more than that. It's a way to help create a different atmosphere, to help recruit and support and maintain your staff. You need to create an atmosphere where people feel really safe themselves in working in that environment. So it's a great question. And in fact, you know, it's I think an important issue moving forward to give people a sense of what that looks like.
Thank you. Another question, interesting one, which has come up is, what's the role of penalties in all this? We've talked about motivating and all that, but is there a role for penalties, and should we have that?
So it's a real challenging thing. I said earlier on, you know, that yes, systems are often faulty, right? And I'm sure everybody has a story on this webinar about working in a defective system where they had to, you know, they had to do unusual things to get the attention and support that they needed, that they should expect to be there all the time, right? But the reality is, if things go wrong and we blame individuals, when the individuals don't have any contribution to that, people learn very quickly that they shouldn't report these things. They learn very quickly that the safest path is just to keep your head down. And that's not the road to improvement. The road to improvement really says, we need to involve everybody. We need to listen to you. And sometimes, you know, we need to admit that things could be better, things could be different. So I think penalties drive safety away. They don't encourage it, except in those rare circumstances, and they usually are rare, where individuals have deliberately violated procedures because they want to cause harm. It's very unusual, right? Usually it's a question of poor training or poor motivation or poor support. It's not a question of people deliberately trying to harm patients.
Thank you. I think that's a very important takeaway that we have, just not about fixing culpability, but building a culture, and people start enjoying that safety environment. As we said, smart people make new mistakes, and that will be the challenge, to make new mistakes. Invited to make new mistakes, not the old ones.
Make them and learn from them, yes.
Yes. Yeah.
Thank you very much for that brilliant talk. And you know, the kind of comments that have come in shows it all. Excellent feedback from all the participants. Really thank and appreciate Dr. Ross and Jennifer for that brilliant talk. And as a mark of appreciation and for taking the time, you know, it's difficult early morning for you. I request our dear past president of ISQua and a good friend of CAHO, Dr. Professor Ravindran Jagasoti, to honor the guests, Dr. Ross Baker and Jennifer, with a small certificate of appreciation. Over to you, Professor Jagasoti.
Thank you. That was a very excellent presentation, very contextual. And I'm sure the whole, this big audience appreciated all the points that you made. And especially, I think the various tools that were presented. I think each will choose what is best for them. So it's my great honor on behalf of CAHO and ISQua to present this certificate of appreciation to both the speakers, Dr. Ross Baker and Ms. Jennifer Gutberg. Thank you very much.
Thank you for that. Thank you very much, Dr. Naveen Thomas, for taking your time and joining us. Professor Ross, Jennifer, Dr. Ravindran Jagasoti, our team at CAHO Secretariat, Dr. Vijay Agarwal, and all the CAHO members and the participants.